Hello and good afternoon. Today, I'd like to welcome everyone that's here today, both our in-person and our online audiences, to this week's OEH seminar. Today, I have the pleasure of introducing our presenter, Billy Quirke. Billy is a research manager with the Partnership for Work, Health and Safety, where he works to address current and emerging issues of work-related health in British Columbia and Canada. His work has covered comparative analysis of return to work across Canadian provinces and international jurisdictions, impact evaluation of the BC Certificate of Recognition Program, and the application of leading OHS indicators to BC industry. Billy holds a Master's of Science in Occupational Hygiene from the UBC School of Population and Public Health, and prior to his work with the partnership, worked as a health and safety consultant with ACSAFE, the Health and Safety Association for the BC Performing Arts and Motion Picture Industries. Without further ado, please take it away, Billy.
Thanks very much, Raymond. Hello, everyone. Sincere thanks for being here today. Today, I'd like to talk about a project on leading indicators, in which we investigated the application of a short survey tool called the Institute for Work and Health Organizational Performance Metric, the IWH OPM, to sectors here in BC, the manufacturing and the long-term care sectors. And for all the folks online, if I'm gesticulating towards the screen here, forgive me. I think Sarah and the rest are going to reel me in. This project was worked on by a number of good folks at the Partnership for Work, Health and Safety, and the research was led by Dr. Chris McLeod. Now, this talk comes in 3 chapters. First, I want to tell you a bit about the strengths and limitations of leading and lagging indicators, and look to convince you that leading indicators are a key piece of measuring safety performance. Secondly, I want to describe the survey itself and how we applied it here in BC. And last, I want to tell you the story of what we saw, the results, specifically how much variability was observed in the survey responses and the trends in that variation, as well as if and how we were able to relate total scores on the survey to past injury rate performance. Sound good? All right then. A few acknowledgements. First, we want to thank WorkSafe BC, as well as the Manufacturing Safety Alliance of BC for their funding of the project. And we also want to thank SafeCare BC, as well as the Manufacturing Safety Alliance, for their key input in industry-specific information, as well as some support with the recruitment. Leading and lagging indicators. What are they? Leading indicators give us a signal before a key outcome or trend, whereas lagging indicators give that signal after a key outcome or trend. And in this way, we can use leading indicators as a indication of future performance, whereas lagging indicators are used primarily for analyzing past performance. And here we have an example of a leading indicator where we see a change in the leading indicator before we see the change in our target. And that gives us a window of opportunity to potentially intervene and make a change before we see any potential negative effects in the outcome of interest. To get us thinking about leading and lagging indicators, I provide a few examples across a number of fields here, because performance measurements is certainly not limited to health and safety. Business, economy, healthy commuting, environmental, academic, you name it. And let's take the last example. If you imagine you are a occupational environmental health student, you have a keen interest in your academic performance. The lagging indicator there is crystal clear. It's your grades. You got an A or a B or a C, but it's grad school, so you probably got an A or a B. As for the leading indicator, there's a variety. There's potentially professor feedback, homework grades, as well as quizzes. Now, what you'll notice in the lagging indicators is that they're typically easy to measure and identify. But they really don't have a predictive capacity, The outcome you get is the outcome that you get. Whereas with the leading indicators, we have that potential to predict the final outcome, but they're much more difficult to measure typically and identify. And if they are easy to measure and identify, they don't always accurately predict the final outcome, perhaps your course grade. Honing in on health and safety lagging indicators now. The health and safety landscape has been dominated by lagging indicators historically. Injury rates, absenteeism, claim costs, and of course the dreaded number of work days without an incident whiteboard that you might see in plants. And for good reason, because they're well understood and they're widely used, which makes them appropriate for benchmarking within and across industries, as well as in and across firms. And they typically provide an accurate assessment of the safety performance up to that point of an organization. But reliance on lagging indicators alone has a number of distinct limitations. Predominantly, that it provides the bottom line outcomes only. Your injury rates, the number of absentee dates, and doesn't provide any information on the risk factors or the root causes of those outcomes. In addition, lagging indicators typically measure negative outcomes, and there's growing concern that negative outcomes do not drive the continuous improvement cycle. And that's for a few reasons. We know that the absence of injury is not the presence of safety. The absence of injury is not the presence of safety. So for example, the majority of firms and employers here in BC are quite small and are only going to experience injuries every couple of years. And when you only see one injury or two injury over 5 years, it's difficult to determine if that's a real trend or if that's random. So relying on injury rates has its challenges there. And we also know, I think perhaps one of the most striking differences between bottom line outcomes and those analysis of the root causes is when we think about occupational disease, where we don't see that outcome, whether it's noise-induced hearing loss or mesothelioma, until many years after exposure. And we aren't going to see that in the lagging indicators until it is effectively too late. Cue the leading indicators. They have gained prominence in health and safety in recent years, and we typically see those as measurements of the health and safety training frequency, auditing, safety meeting participation, as well as a number of others. And the benefits there is that they provide potential identification of those causes before those negative outcomes. And they work in tandem very well with leading indicators and are best used in concert to balance the challenges of both. Now, this research is being conducted to identify and help improve the scientific evidence around the use of leading indicators. Despite their common and widespread use, there isn't a lot of evidence supporting their impact on injury rates or other outcomes. And also, if you're a health and safety professional, typically you're left up to yourself to decide what leading indicators to track and how to do that. There's also a real need for implementing more standard practices for them. With that, I will move to how our team applied the IWH OPM. We'll talk about what the survey looks like and how we used it. So in response to the lack of scientific evidence, a group in Ontario led by Dr. Ben Amick partnered with the Health and Safety Ontario to bring together leading industry health and safety professionals, policy regulators and developers, as well as work and health researchers to identify the key characteristics that determine safety performance. And what they distilled their work down to was 8 key questions that were then used to create a short health and safety practices survey that could be used to quickly assess performance, not a detailed audit that can be rather cumbersome. Instead, we're looking for just rapid differentiation between high performers and low performers. This tool has been used in Ontario, Alberta, Saskatchewan, and New Brunswick, as well as a number of other jurisdictions. And what they've found is that the scores are related in expected ways to injury rate performance, both historically and in some cases to be predictive of future performance. And as a result, this tool has the potential for prevention, evaluation, and also for benchmarking. Here's the survey itself, designed to be completed in under 5 minutes. We've got our 8 questions up front, and then also a number of demographic questions as well. And I highlight 3 of them here just to give you a flavor. We're talking about access to information. Also, do workers and those who are in charge of safety have the authority to make changes? And does everyone have the tools and equipment they need to complete work safely? The way that the questions are framed in the survey is an attempt to do so as objectively as possible. So we're looking at the percentage of time that each of the following practices or policies occurs in an organization on a scale of 100 to 80%, down to 20% to 0% of the time. And in doing that, we can create a total score in which we assign a score of 5 to those who receive 100 to 80%, versus a score of 1 for those that report completing that practice 20 to 0% of the time. Summing all those up, we get a range of total scores from 40 to 8, and nobody gets 0, and that's because we're nice. WorkSafe BC approached our group to implement the survey here in BC as an OHS indicator tool and to investigate its utility in our province. We used the survey to collect baseline information in the long-term healthcare and the manufacturing sectors. The Health and Safety Associations provided us contact information, and we reached out to those organizations first by phone and also by email, requesting that we get 2 surveys from each employer, 1 from management and 1 from employee. Once we had contacted folks at the organization, they then provided us the contact information for those 2 folks, specifically selecting them for the individuals who were most knowledgeable about health and safety practices for the organization. And once that was provided, we sent them the link to the online survey. All right, let's talk about what our samples look like, both the long-term care and the manufacturing sector. In long-term care, we were interested explicitly in residential facilities that provide direct patient care and groups that had both eligible phone numbers and contact information. Organizations that we weren't interested in, that were out of our scope, were those in which there was not direct patient care conducted, those we couldn't contact, specialty groups like acquired brain injury, as well as very small firms, private homes and group homes. As for the manufacturing sector, we included everybody in our sample that was a member of the Manufacturing Safety Alliance. That's the Health and Safety Association for the manufacturing and food processing industry here in BC. And within that are 3 distinct groups of employers. The first are the general manufacturing firms, and then we also have the certification of recognition firms. Those are groups who have gone through certified health and safety management system audits. And third, we have the safety charter signatory firms. These are organizations that have a commitment from senior management to safety excellence. And if you caught Sean Tucker's talk last week, he mentioned that much of his research on CEOs and safety flowed from his work with a similar group of organizations, the Safety Charter group in Saskatchewan. And those that were ineligible, those that fell outside of our study scope, non-contactable, those that were closed down, and those that really weren't operating within manufacturing, sort of industry and government associations. How representative were our samples that responded to the survey? So for long-term care, we had 93 respondents for a 36% response rate. And in manufacturing, we had 139 firms. So slightly more, but a lower response rate of 18%. In application of the OPM in other provinces, we've seen a range of response rates between about 15% and up to 40%. So we were quite pleased with our response rate in the long-term care sector and satisfied with the manufacturing group at 18%. And we attribute that lower response rate to a shorter recruitment period, as well as survey fatigue. We got the sense that there were a number of other surveys in operation at the time, whereas in long-term care, we were viewed as very novel as conducting a survey on health and safety practices in that group. For the long-term care, their baseline injury rate is very high. It's about 1 in 10 individuals injured on the job every year. When we compare our responders to our non-responders, we saw that the responders were typically larger and typically had slightly lower injury rates. When we move to manufacturing, we see a relatively lower injury rate risk, but still high at about 6 folks per 100 person years. The non-responders versus the responders were quite consistent in terms of size and background injury rates. When we look within manufacturing responders, we see that the general manufacturing firms were slightly smaller than our core firms and our safety charter firms. And when we look across manufacturing and long-term care, we see that the core subsample was most comparable to the long-term care group. Okay, closing on chapter 2, and let's get into what we found. We want to talk about the variability we saw and the trends we saw there. I'll first show the questions one by one, what those distributions of responses look like, then take those questions together as the total score for the long-term care, for manufacturing, and then for the 3 groups within manufacturing. Question 1. Everyone at this organization values ongoing safety improvement. So here we have plotted the percent of firms that perceive this question as completed between 0 to 20% of the time, up to 80 to 100%. And what we see in long-term care is that about 80% of the organizations report that everyone values ongoing safety. And we see a similar, but slightly shifted out to the left, proportion of folks in the manufacturing group, with about 70% of organizations reporting that everyone in the organization values safety improvement. Moving to the second question on putting safety on par with production and quality, we see a very similar trend between long-term care and manufacturing. Again, in manufacturing, slightly fewer folks reporting that it's completed the vast majority of the time. Question 3, again, a similar pattern in which manufacturing, slightly fewer forms reporting, but generally a very consistent trend. Now, when we move to question 4, we see a difference. Again, similarities between industries, but we see far fewer organizations reporting that employees are always involved in decisions that affect their health and safety. Around 40% for both the long-term care and manufacturing. We see this where over half of respondents identify an opportunity for improvement, and we report that back to each individual industry health and safety associations. Those in charge of safety have the authority to make the changes they identify as necessary. This looks a lot more like questions 1 through 3, and with the distinct difference that it is the only question where the manufacturing firms reported a markedly greater percentage of folks to regularly complete this practice. Those who act safely receive positive recognition. Here we see a similarity with question 4, where for the majority of organizations in our study, that was viewed as occurring either moderately or infrequently. Next, we have everyone has the tools and or equipment they need to complete work safely. A similar pattern, very near identical, between long-term care and manufacturing. And lastly, with question 8 on audits, for the first time we see a difference across industries in which manufacturing organizations report completing regular audits at much less frequent rates. And we hypothesize here in our discussions with respondents from both industries that the long-term care have patient safety at the front of their minds and patient safety audits, whereas manufacturing, when you speak of safety, you're clearly talking about worker safety. And there's some indication that formal safety audits were being perceived as patient safety audits in this instance, and perhaps that manufacturing was providing a more accurate picture of the frequency of which these audits were being conducted. So all those 8 questions taken together, we see reasonable variability in a small number of questions, 4 and 6, and very similar patterns with lower variability for the rest of the questions. Now, let's look at the total scores. First, we'll look at long-term care. And we plotted the distribution here of the percent of all respondents up to 20% against the OPM total score. And what we see in the long-term care is that we have about 15% of organizations reported perfect scores, so having very little opportunity to improve policy and practices. And then the majority of organizations leaving some small room for improvement with scores of 35 up to 39. Manufacturing, we see a different trend. We see only about 7% of our organizations, far fewer than in long-term care, are reporting perfect scores, and that the whole distribution is shifted out to the left slightly, with a slightly larger number of very low OPM scores, so this practice is being completed infrequently, and a greater proportion in our Tier 3 and Tier 4 groupings. Bringing them side by side now, recall that long-term care had a much higher injury rate risk than manufacturing. And it's interesting to note that while that's the case, we see scores for the long-term care sector typically reporting their policies and practices much better than we do in manufacturing, where the injury rates are considerably lower. Next, we want to understand further and unpack manufacturing and see if there's any influence by our 3 manufacturing groupings. And here we break out the core and safety charter firms, those firms that have high level of engagement with their health and safety policies, versus those that are general. And what we see here is, again, fewer folks and employers reporting high OPM scores in the core and safety charter grouping, providing another small indication that folks who are well educated and trained in health and safety may be providing a more accurate description of their health and safety policies. In engaging with these organizations, we know we were connected with the right individual who was most knowledgeable about their practices, whereas we didn't have that same level of confidence in the general firms for manufacturing as well as in the long-term care sector. Okay, moving to injury rates, what we all want to hear about. We're keenly interested in if there's association between OPM scores and the firm injury rates. And what we'll first look at is the long-term care sector. We'll then look at manufacturing, and then we'll move again to unpack those three groups within manufacturing. What we did is calculate the firm level injury rate for each of the organizations participating in the OPM scores, and we took the average injury rate from 2012 to 2014 on long-term disability and short-term disability claims, and then linked those two data sets together, the OPM scores and the injury rate data, for us to investigate that relationship. And what do we see for the long-term care? On our y-axis is our injury rate for short-term disability and long-term disability claims. And our x-axis, we have the OPM scores, ranging from a score of 20 all the way out to our highest performers of 40. In short, no relationship. We see that our slope coefficient here is effectively 0, in which individuals who scored higher on the OPM are just as likely as those who scored lower to have high injury rates. And this stands in contrast to the research that has been conducted across Canada so far, particularly in the long-term care sector, where a strong relationship was found for nursing homes and other similar groups. How about the manufacturing sector? What do we see there? And the answer is a modest relationship in which we see firms that perform particularly well on the OPM to have slightly lower injury rates than those who score lower. So while it's not marked, we do see a slight decrease in injury rates with increasing score performance. We wanted to go one step further to investigate if these results in manufacturing were being driven by the different groups there, whether they were the general, core, or safety charter firms. And what we see is quite interesting. We see for the general group, no relationship with the OPM score with claim rates. But for our core and safety charter firms, we see that the moderate relationship we saw in the past slide is driven almost exclusively by the core and safety charter firms, those groups who have a commitment to exceeding health and safety regulations, to the tune of about 25% in injury rate between our lowest and highest performers. And this, again, provides, we believe, more evidence that the core and safety charter firms may be most accurately assessing their health and safety practices. So our main findings. First and foremost, we were pleased to see the establishment of variability in both sectors, manufacturing and long-term care, but particularly in manufacturing, because without establishing that variability from the get-go, we're unable to play or relate those to injury rates. And as for the evidence, of the OPM relation to injury rates, it's mixed. As a whole, the OPM was not associated with injury rates in the long-term care sector, but in additional research, we've shown that there are certain questions within that group. We do see that the OPM is more strongly associated in manufacturing, but as we reviewed, it's solely due to the inclusion of the safety charter and core sample firms. And one of the biggest challenges we observed in conducting this survey was ensuring that we connected with the right person in an organization. When we enter an organization, we typically were connected with an administrative or a human resources individual who was then responsible for connecting us with both a on-the-ground level employee as well as top management who could give an accurate depiction of the health and safety practices and policies for that group. And in conclusion, we see the OPM as a useful introductory tool in the long-term care sector. Its responses indicate clearly that there's a need to further understand the link between perceptions of health and safety, as well as with injury outcomes. And while the evidence is indeed mixed, it's the aspiration of a short tool that can be completed in under 5 minutes that may be able to differentiate between the high and low performers instead of using a very comprehensive, occasionally cumbersome audit that is very appealing and worthy of further research. And as for the manufacturing group, we find these very interesting. It suggests that these core and safety charter organizations have a much more realistic sense of where their health and safety policies and practices may stand. Future research for this project, keenly interested in linking into national organizational performance benchmarking initiatives. They're currently being used across a number of provinces, including by Sean Tucker in Saskatchewan. And as well, we want to look to increase our potential sample size if given the opportunity in both the long-term care and manufacturing groups, and also apply the OPM in additional BC sectors. And that's it. Thank you very much.
Great. Thank you, Billy, for the wonderful presentation. I'd like to open the floor to the audience to ask questions.
Hello, Billy.
Hi, how are you?
Thank you very much for the presentation. It's very interesting. One question that I'm curious is, so you send out 2 surveys per firm, right?
Mm-hmm.
One goes to the employee representative, one goes to the executive.
That's exactly right.
Have you looked at how different the response in these 2 groups? Are they very different or are they pretty much the same?
Yeah, I'm glad you asked. So what we found when we looked at demographic factors was that the responses between employee and management representatives didn't matter significantly, that both employee and management were equally likely to rate their total scores high or lower. And related to that idea, we also wanted to know, well, do health and safety professionals rate their scores higher and lower? Because that was observed in other applications of the research in Ontario. We didn't see that trend. Health and safety professionals were found to be just as likely to rank their performance as high or low. With the one exception where we saw differences was in the long-term care sector. We asked folks if they were involved in direct patient care in the demographic questions, and we noted that performance was ranked slightly lower for that group of individuals in long-term care, those who had direct patient care on a daily basis.
I've co-opted the microphone because I was next to Angela. I don't know if anybody else had their hand up, but I'm going to steal the opportunity. Thanks, Billy, very much. A crisp and clear presentation. I have two questions for you. Some might suggest that the response rates are quite low, and I wonder if there's any mechanism by which you can link the non-responders to their claim experience to at least compare the non-responders, that those who are not responding might be one of two things: not so great in their claim experience, and you're missing that in the data, or just great performers who say, I'm not going to bother with this. So I'm just curious whether that's feasible. The second question, I'm drawing a blank on, so I'll let you answer first.
Certainly. Yes, a very important next step in which we know that in long-term care, those non-responders were slightly smaller and did have we actually have higher injury rates, and we saw that those were actually consistent in manufacturing. So further understanding of that non-responding group is a very key piece, both on the back end, looking to compare those on key characteristics, but also on the potential to collect further information and gather a greater number of those non-responders into the survey.
Remembered my second question. You suggested that the results for long-term care here were not the same as the results you're seeing or other people have seen for the OPM or for leading indicators. I'm just wondering, is that do you think that's something to do with BC or the response rate, or why do you think you're seeing what you're seeing for long-term care with no effect?
Yeah, so one of the potential explanations is that we were brought in to benchmark the scores on the OPM prior to the creation of a health and safety association for the long-term care industry in BC. Conditions in Ontario and in other provinces are different, where those health and safety associations may be already established. And the potential is that perhaps long-term care has less of a ingrained health and safety culture, or is in further development here in BC. And it may also relate to the capture of firms, where we have about 38%, but we need a further understanding of that other group here in BC.
Thanks, Billy. That was, as Mika said, very, very clear and very interesting. I have a couple of questions too. One relates to your original concept of leading and lagging, and I just wondered what was the timing of the data that the injury data you were using compared to the questionnaire, and is there a possibility that it's reverse causation here?
Yeah, thanks for that, Hugh. So the injury data relates to 2012 to 2014, and we took the average of those injury rates, and then the survey data, so the time at which we measured performance, was done in 2015 and late 2014. So again, we aren't able to speak to the causality of those. We're simply looking for an association in that case. And what they saw in other applications is that higher OPM scores were related in the past to lower injury rates, and then in controlling for previous injury rates, actually predictive of future injury rates, that score at that time.
Okay, that's great. Yeah, thanks. And then the second question had to do with the companies that had the low OPMs. Was there a size relationship? Because you mentioned that small companies have typically not necessarily lower rates, but I just wonder if those lower numbers could be less stable, and whether if you remove them in some way or could weight them in some way, that might give you a different perspective on that relationship.
Yeah, we took a look to ensure that those large employers although there is that difference in the number of large employers who are in our subsample, we did find that large employers were equally as likely, for the most part, to score high or low on the OPM.
Thanks, Billy. We've got some online questions here, sort of specifically around this question of patient safety versus worker safety. And so when you distributed your questionnaires, did you differentiate between patient safety or worker safety? Or was this just learning afterwards that workers may be gearing the questions towards patient safety?
So in the survey itself, we explicitly stated occupational health and safety of the workers. However, this was a sort of learning as we went in our conversations with individuals when we pick up the phone and talk to an organization, that we realized that at certain times we're speaking different languages, whereas patient safety is such at the forefront of folks who work in the long-term care industry's mind, that was being considered when filling out the OPM. We can't speak to if that really did have a large effect or not, but it is one of the things where is an interest, particularly between manufacturing. We don't have that concern.
Okay, and then somebody else says, sorry, I'm trying to get the questions before they disappear. Not going very well. Oh, I totally lost this question. I'm so sorry. It had to do with accreditation of these facilities and whether or not you stratified by their accreditation status.
Not easy to scroll with a trackpad.
No.
Sorry, could you repeat that?
Here we go. In my experience, healthcare supervisor, their workers less work. In my experience, healthcare supervisors, their workers. Oh, I'm having a really hard time. Anyhow, the question is, did you stratify by accredited institutions for the long-term care facilities?
No, we didn't investigate accredited institutions. Wasn't a demographic valuable that we captured, but could potentially provide interesting relationships if we saw those accredited institutions performing better.
Okay. And then coming from a safety industry, I found that healthcare industry very challenging. Healthcare workers are drawn to their job because they care. They care about their patients' safety, and their patients' rights, sometimes beyond their own safety.
Yes.
That's just a comment, I think.
Yes.
Another question further up here was, is there a better way to determine the OPM scores besides a questionnaire?
Yeah, we have seen application of it both in worksite visits in other jurisdictions with a clipboard and a written paper version, as well as making that questionnaire available